Thank you very much for coming tonight. I did one of these a couple years ago, and I think there are like 10 of you here. So this is already an improvement. I'm going to try to stay relatively stationary because the cameraman, I think, is already getting a little twitchy up there. He's a little nervous that I'm going to wander. My reputation must precede me. When I was asked to do this, I lecture routinely throughout the country on the fascial distortion model itself. And so what we teach, there are 20-hour courses. We have 3 different courses. I teach those wherever they'll entertain our course. That's not what tonight is about. What I wanted to do is I wanted to talk about kind of the osteopathic approach, maybe why Fairbanks is unique in that we have a large osteopathic clinic in town. I recognize a lot of faces. The clinic itself is a success because of the fascial distortion model and the way of looking at it and incorporating all of osteopathy. So I was going to talk about pain because if we knew how to deal with pain, we wouldn't be in a pain crisis, right? We wouldn't have all the issues we do. I know that in my heart that if we can get the fascial distortion model to spread in medicine, some of that will help. It's not the answer to everything. We don't have a single answer to this issue, but if we can learn to address pain in a different way, we can often get different kinds of relief. She already covered most of this. I work for Tanana Valley Clinic, happy to be part of Foundation Health Partners. I serve as a regional assistant dean for Pacific Northwest University. So many of the students that you guys have encountered in town in various specialties are actually up here as students for 2 full years. They only leave to do their audition rotations to figure out residencies. Then we also have we're lucky to have the whammy students that are the MD students. So you will see doctors of osteopathy in training throughout Tanana Valley Clinic, Chief Andrew Isaac, the hospital. They're all over too. That's part of what I also help coordinate. So I tried to come up with some goals. And one of the goals is to discuss inflammation as a source of pain and how it kind of pervades our medical thinking. Also how I think it's a little bit too much the forefront of what we're treating. I want to discuss what is a differential diagnosis and how we can reevaluate some of the things that are getting treated in medicine. And I wanted to discuss osteopathy itself, how the philosophy and treatment can change the perspective. And so turning the differential diagnosis upside down sometimes can lead to more effective treatment. So what is inflammation? It's part of the body's immune response. We have inflammation. Without inflammation, we wouldn't heal. That is a big part of the inflammatory response. It's required for healing, for fighting infection. Overall, that's what makes us function. However, inflammation unchecked leads to a lot of problems. It leads to possible cancer, heart disease, a lot of different issues are inflammation that is kind of gone awry. Inflammation is the process by which the body's white blood cells and the substance they produce protect us from infection, foreign organisms, bacteria, and virus. Okay? So when your body recognizes something foreign, it mounts an inflammatory response. And that inflammatory response is mediated by the blood cells. And it dumps all of this they're like little firefighters, dumps it into the system, and it goes around, tries to break down whatever is bad. Well, sometimes that system is out of control. Sometimes that system is revved up based on what we're eating, stress, all of these things. And when that is not being controlled, then we run into problems where you have chronic inflammation, okay? So example is like arthritis. The body's defense system sees no foreign body, no foreign object, but it's still fighting this, it thinks it's fighting an issue. Basically, it's fighting yourself, and that's called an autoimmune disease, okay? We hear arthritis as the cause of a lot of pain, and I often teach that arthritis, this kind of arthritis, the autoimmune arthritis, is different from wear and tear arthritis. Wear and tear arthritis is not as big a cause of pain in my experience as this kind of arthritis is. So the body's normally protective immune system causes damage to your own tissues. That's when we have to learn and figure out how to control that inflammatory system. On the radio interview, I don't know if anybody heard it, one of the announcers said, well, what about diet? So I stuck this slide in. This is my one slide infomercial on diet. 5 years ago, I would never have made a comment, probably publicly or in the clinic, of how important our diet can be in controlling that inflammatory response. It has blown me away with all of the patient experience over the years about how when we find what mediates our own body's inflammation, how that can solve a lot of our own problems. So we have patients who have multiple joint aches. They go into the doctor and they have terrible knees or a bad shoulder or whatever the situation is, and they get the diet talk, which I call it that because we do it all the time. It's like telling people to quit smoking. You tell people to eat right and what to eat, and nobody listens, and you tell them, and then you get the one person who comes back and says, I listened to you and I changed my diet. Dr. Simon will tell you, we all kind of go, what? You listened to me? What? How many times do you have to tell a person to quit smoking before they do it? And it's been studied and shown to be about 40 times. Diet is probably more because it's very hard to change our diet. But with that being said, we can see a lot of inflammation in our body comes through the stomach. So when you eat something that you're sensitive to, you're not allergic, you're not going to end up in the emergency room, but your body is sensitive to it. It dilates the pores of the stomach and the bloodstream, and it absorbs this thing, this allergen or this sensitizer across the stomach barrier or the colon and the small intestine, and it revs up your autoimmune system. So now your autoimmune system, that thing you're trying to fight, causes a vicious cycle. So once you have caused irritation of the stomach wall or the small intestine, the pores get bigger and more things come across. The bigger the things that come across the small intestine and the stomach, the more likely they're to be recognized as foreign. Once they're recognized as foreign, your body fights inflammation and you get this cycle going. This is where the gluten-free craze, everybody's seen stuff that's gluten-free. It's a real issue. It's a real issue. Some people will say, is it the wheat? Is it the dairy? Is it the actual gluten itself? Is it GMOs? Is it Roundup? We don't know, but we know anecdotally that a lot of people, when they stop whatever agent is offending their system, a lot of their symptoms get markedly better. I had a patient not too long ago that the gluten was a big trigger for their headaches. I have one lady that I remember distinctly. We worked with her for a couple of years, and finally her child had a rash, and she needed to get rid of eggs for the child's rash, and her back pain resolved. And so there's a lot of things. That's why I put up the Whole30. If you can go through an elimination diet of figuring out what is your trigger, you can have significant improvement in your own musculoskeletal pain, and maybe even further reaching. If we think about inflammation as possible cause of heart disease and other artery issues like hardening of the arteries we talk about in the legs, peripheral vascular disease, if we could trigger that early and you find out you're lactose sensitive when you're 20, you don't have 50 years of misery. My dad has Parkinson's disease, and he was in his mid-70s when I found out, and I mentioned to my mom that he should try to stop gluten and dairy. His entire digestive process changed, and he was much happier. We can become sensitive to anything at any time. So it's a constant kind of monitoring. I recommend that we investigate that anti-inflammatory diet, which is more green leafy vegetables, less meat, no refined sugar, all of those things. That's kind of a whole separate talk, but because it was brought up on a radio show, I was like, you know what, I think we probably should touch on that, because if you listen to nothing else tonight, those two things, kind of an elimination diet like the Whole30 and the anti-inflammatory diet as part of your whole health plan, I think that's going to have a big impact. Okay. So while inflammation is incredibly important, and we need to address it as part of healthcare, is it really everything? You know, in my practice every day, I see patients who come in and have been told they have arthritis or inflammation, and they're constantly being treated for inflammation, but they're not getting better. If we were getting better, if inflammation was the cause, then we wouldn't have the problem we do with pain, right? So if the doctors were always right, me one of them, if we were always right, it'd be like one solution, you get this pill and you're good. What I thought was interesting, we see ibuprofen, naproxen, Advil, all of these different drugs that are some of the same names. Look at the amount of money that we spend. The bottom line here, the analgesics, internal, meaning pills, $4 billion is spent on over-the-counter analgesic every year. And frankly, a lot of those are pretty bad for you. If you take them long term, they can cause blood pressure issues, they can cause kidney issues, they can cause gastric bleeding. So we all are thoroughly ingrained, $4 billion of spending worth, that if you have a problem, it's probably inflammation and you should take Advil or naproxen or whatever, ibuprofen. Probably should use the generic name. But it's pervasive in our society. If something hurts, you should consider an injection of cortisone. What is cortisone? It's an anti-inflammatory. So everything we're doing not everything, but a lot of what we're doing in medicine is trying to attack inflammation, okay? So what is a differential diagnosis? And I went to the all-authoritarian Google dictionary to come up with the answer, right? Isn't that where we find everything now? What, Encyclopedia Britannica must have just like evaporated. I don't know where it went. The process of differentiating between two or more conditions that share similar symptoms. Okay, so pain is a very broad definition. What do you have pain of? And then you have, kind of you got to go down the list. So a physician places the most likely diagnosis on the top of the list. The list can be fairly long, and you want to rule out things that are really dangerous, okay? So I picked a common ailment that we all have experienced, the sore throat. The most likely cause is probably a virus. Next likely cause is probably strep. So we all know that if your sore throat lasts a little while, you should go to the clinic and get a strep test and possibly an antibiotic. I can tell you over the years of working at First Care, we used to have to spend hours convincing people not to take an antibiotic. You don't need an antibiotic for your viral sore throat. I think we're seeing a culture shift, at least by the time I was done. Then I was getting patients coming in saying, no, you really need to take this antibiotic. You have strep. And they're like, no, I really don't want to. So those two are high on the differential. There's a lot of bad things way down the list. Look where this person is holding. Do they have a thyroid issue? Do they have epiglottitis? Do they have some sort of growth in their throat? All of these things are on the list. What we want to do is, in healthcare and in our own body, we want to take care of the easy things first, make sure that we think about those, rule out anything that could be seriously dangerous. But as a health system, we want to treat simple to difficult. So if I come in with a sore throat tomorrow to the doctor, I don't get an endoscopy because I have a sore throat, right? I don't get the several $1,000 hospital bill that says, oh, yep, your esophagus is fine. We think you have a virus, okay? So let's talk about musculoskeletal pain, right? So you have some shoulder pain. We know that shoulder pain is really common. Any joint, pick a joint, and you probably know yourself or somebody else who has that. What are the diagnoses? First of all, anybody with shoulder pain, they all think it's their rotator cuff. I think it's one of the things that everybody knows they've got one. It's got to be the problem, okay? So what's the standard? Say you hurt your shoulder. You're out playing basketball and you hurt your shoulder. What are you going to do? Patients do this almost intuitively, sometimes not in Alaska, because Alaska, we're a little bit different. We have students up here all the time and they shake their heads and they see how active our population is. They're like, this isn't normal. And it is different. It is different up here. But a patient injures their shoulder, you're going to put some ice on it. You may take that ibuprofen over the counter and you're going to give it a break. You may not totally immobilize it, but you're going to stop using it because it hurts, right? You're playing basketball and now it hurts a little bit. So you take a break. What are you treating? You're treating the inflammation. So, it's hard to get in unless you go to First Care or the emergency room. it's hard to get into your doctor, so it often takes a while. So you do that for a couple of weeks, and you've just given an adequate break, and it's calming it down. So you go to the doctor, and what often happens? You might get a prescription for more anti-inflammatories, right? Because it's inflammation. You did this to your shoulder, therefore it's possible inflammation. You may end up with an injection or some other procedure to treat the inflammation. If you get imaging, they're simply looking to find torn, broken, sprained, or inflamed. Okay? It's a very orthopedic way of looking at the body. So if you have shoulder pain and they take an x-ray, that's what they're looking for. You may get referred to physical therapy. Physical therapy, you're often sent because that injury was you were weak. So when you threw the ball, there was an instability, a weakness, and you hurt yourself. Okay, so often the perspective is we need to strengthen something. Okay, well, in my experience, you didn't become weak in between throws or shots, right? You didn't suddenly one day you're shooting the basketball, sudden weakness developed, and now you got pain. Now you could have structural problems that are due to weakness, but what happened is somehow there's inhibition in your shoulder, and that inhibition is preventing a muscle from engaging. Okay? So I like to think we're trying to get things to engage. And what am I talking about here? So physical therapy is an extremely valuable modality. It's very helpful. It's often incorrectly used by the medical system, meaning the physicians. Anybody here a physical therapist? Okay, I'm not going to get... so I refer to physical therapy. It's great. We teach physical therapists the modality we use, and I work with a lot of physical therapists. I was looking for validation that they get used incorrectly, because they do. They get referrals. It's basically patient has shoulder pain. Deal with it, and that's what they're left with. So they don't have a great referral coming to them. Not a lot of direction. I have an example. I was at the Cleveland Clinic a couple of months ago, maybe a year ago now, and a woman who was in their administration department we were teaching a course, and they were asking for volunteer patients. And a patient came in, and this guy down in the corner is demonstrating a one-legged squat. She came up and she said, okay, I have hamstring pain. It happened 18 years ago. And she showed us her hamstring pain, and she said, I've been unable to do a one-legged squat. And I said, yeah, me too. So what's the issue? And she said, but I can on the other side. And I was like, okay. And we talked to her and we said, what have you done? She's taken anti-inflammatories. She has done physical therapy for 17 years. And I was like, so at what point, if her hamstring should have looked like this, right? I mean, she'd have like the Tyrannosaurus Rex hamstring on one side and nothing on the other. But her goal was to get back to that point where she could do a one-legged squat. So the system, the medical system kept saying, it's inflammation, we got to calm down the inflammation. And they kept trying oral steroids and the Advils and the NSAIDs. And then they tried the physical therapy. So I joke with my physical therapy colleagues when we teach is, at what point do you terminate therapy? Is it 18 years? Is it 19 years? Because apparently 17 years we're going to keep going. And talk about dedication. I don't know that I'd do anything for 17 years, right? So we treated something on her, and it took about 30 seconds in front of the group, and she could do her one-legged squat. That's what I want to talk about tonight, is how can we put something as simple as a 30-second treatment in front of the 17 years of repeating the same thing, okay? So I think we have blinders on in the clinic because we're all trained very well and very consistently. When you walk into a family practice office, you are going to be fairly consistent throughout the United States. It's one of the benefits of strong Board of Family Medicine, whether you're DO or MD boarded, the same material is tested, it's taught the same way, and I think that's a lot of the reason we have some of our issues, is because new things trying to get in there, like what I teach, is dang near impossible. Because I got to have the evidence before anybody will listen. Evidence is great, but anecdotal, I treated X and they got better, isn't good enough. So if I want to get a change to happen, I have to quit my career, go into research, figure out how to do all the research, and then present it. But we know we can make serious changes. We can change the perspective. So what I spend a lot of my time doing is going around to various cities. We work a lot of osteopathic medical schools. I was recently at the AOA Sports Medicine conference, taught at the Cleveland Clinic, Mayo Clinic, all within about a month of each other. We're trying to teach more and more people just exactly what it is that we're talking about. And we're trying to change their perspective. So this is something I like to show because it's really about changing perspective. Who sees the arrow? Okay, that's like 6 people. Okay, I don't know if it'll show up here. See the arrow? We change your perspective. Now when you see a truck or a van or anything, you will not, I mean, it's going to be hard not to see it, right? It's that simple, it's that fast. So that is what we're trying to do with physicians, is change their perspective. Give them something to see that they haven't seen before. And it's actually quite simple. We're trying to pass along a different model that provides a physician with another tool for evaluate. Does it replace or push away anything? No. Medicine has been well studied and researched, and we have a lot of reasons for what we do. But in my clinic, every day, somebody comes in who's been like that 18 years of pain or 2 years of pain, and in a couple of minutes, their pain is much improved. May not be gone, and it may not be the entire solution, but as an osteopath, we want to relieve pain so you can be active. Once you're active, you improve function, you can heal yourself, okay? So the example I have on my slide here is inflammation and the orthopedic model. Very, very often you go into the orthopedic model of care and it's inflammation. And I have seen people who will have the NSAIDs, Advils or the Aleve. They'll get oral steroids, which are an anti-inflammatory. They'll get oral steroids again. They'll get a shot. They'll get another shot of steroids trying to reduce the inflammation. And this just keeps going on and on and on. And at what point do we say to ourselves, you know what, maybe it's not inflammation? My personal favorite was an MRI reading by a radiologist of the patellar tendon. The person had pain in the patellar tendon, and the reading said, and it was one of those rare radiology reads that was very specific. Often the radiologists kind of hedge around and you read it and it's like a novel and you're trying to get to the bottom line. This one was, there is absolutely nothing wrong with the patellar tendon. There is no inflammation, no tear, no strain, nothing. It looks normal. The diagnosis from the orthopedist was patellar tendinitis. Tendinitis is inflammation. So you got an MRI, which is probably the most sensitive test for inflammation, saying there is none, but that's how we treat it. Why? Not because they did anything wrong, but that is our perspective. So we want to change that perspective. If you look at this slide, if you remember this movie, this is Nicolas Cage in National Treasure. At each time he changes those little lenses on those glasses, the back of the Declaration of Independence changes and you get a different map. And that's what learning about fascia and the fascial distortion model shows. So I wanted to focus more on general osteopathy than fascial distortion model. Fascial distortion model is my passion, and honestly it's why Foundation Health Partners Tanana Valley Clinic has a program that has just hired its 4th full-time physician. We have a 5th person who's a combination of 2 of our providers. And then we have a lot of the practitioners at TVC who use this in some form during the clinic. All names you'll recognize: Dr. Acola, Dr. Lessner, Dr. Stoltz, all MDs, but they use osteopathic principles through the fascial distortion model because they've been exposed. So their perspective has changed, okay? When I talk about differential diagnosis, when you come in with shoulder pain, I don't want the first thing that we do to think that it's inflammation and we're going to give you a pill or an injection. I want, okay, it could be one of our 6 distortions, ways you can mess up your shoulder. And if it's not one of those, then we go down our cascade of differential diagnosis. Now, if you can't bear weight on your leg, a fracture goes up way higher. Or if you have a fever and it's sudden onset and there's redness, we got to rule out an infection. So we want to make sure that the differential diagnosis, it's a medical model, so Bad medical things always have to be ruled out. What we want to do though, what I'm striving to do, and to get it into the medical schools, both osteopathic and MD, and no matter what specialty they're in, is you want this in the hands of the doctors so that when they look at you, they can look at something simple first, rule that out, and then move forward in the differential if it doesn't work. I had a lady probably 8 years ago now. She came in with abdominal pain. So where do you go if you have abdominal pain? Emergency room, right? So the emergency room works her up, finds nothing terrible, which is their job, right? They don't want anything bad happening. They send her back to her primary, and her primary does a lower endoscopy, an upper endoscopy, lab work, all appropriate for abdominal pain, okay? So they work through this process. Well, they don't see anything, so they do a CT of the abdomen. CT of the abdomen doesn't show something, but there's a little weird thing on the liver, so they do an MRI of the liver. So now we've got, you know, are any of you like calculating this in your head? I mean, me as a patient, I'd be going, oh, when does this stop? She got another lower endoscopy, which I still don't know why. She got a lower endoscopy. When she came to me, I said, well, where's your pain? And she showed 3 spots right by her belly button. And I touched them like this light. And she's like, ow. And I'm like, so has this been your pain all along? She said, yeah. Her pain was not inside her abdomen. It was on the surface. And so she had fascial distortion on the surface of her abdomen, which, you know, did she need to go through all that imaging? Made my job easy because they eliminated all the bad things it could have been. Right? I had a patient the other day, they had done a bone scan, an MRI, and it gave me total carte blanche because I knew no matter what I did, she didn't have anything terrible in her spine because it was all ruled out. But if we're looking at trying to deal with the healthcare system and over expense, maybe we should have tried some other stuff before we got to that. So I'm very proud that Fairbanks has grown to support an osteopathic clinic. Not long ago, the osteopathic hospitals were closing, and they were shutting down, and they were integrating into just the regular hospital system. We've grown this clinic from one person doing half-time manipulation to this current state. It's pretty impressive. Osteopathy is based on the work of Andrew Taylor Still. He was an MD. He was originally expressed his principles in 1874. So this isn't new, okay? Today, osteopaths are fully licensed and trained side by side with MDs. In fact, all residency programs, I believe next year, will merge, so they'll train MDs and DOs together. I train side by side with my MD partners, and in fact, I'm MD boarded, which means I didn't take the osteopath boards, I took MD boards. So any of the MD family practice doctors in town that are board certified, I have the same board as them, but I have the osteopathic training behind it. Interestingly, and I will always admit, that the osteopath profession was not as always academically adept as the MD profession. So we had a lot of stereotypes and carryover of some criticism of the osteopathic profession, which I think in an era of more official scrutiny, there's essentially not much difference in the academic quality of a DO and MD. I don't think we can say that for always. The Flexner report, which happened about 100 years ago, a little over 100 years ago, that cleaned up all the medical schools, both DO and MD, but it didn't eliminate some of the problems. So, but today, you probably don't even know if your physician doesn't do osteopathic manipulation on you, that they're a DO. There's a lot of DOs in this town. Dr. Triplehorn doesn't do a lot of manipulation, but if anybody's ever had a sleep study, he's a DO. There's a lot of different DOs. We have orthopedic surgeons, OB surgeons, internists, family docs. We have a psychiatrists. They don't necessarily use the manual techniques of osteopathic manipulative medicine, OMM. Okay? So osteopathic manipulative medicine is a hands-on treatment. Okay? We use our hands to diagnose, treat, and try to prevent illness or injury, but also to address injuries that have occurred. I did edit this because it said, using OMT, your osteopathic physician will move your muscles and joints using techniques including stretching, gentle pressure, and resistance. I just figured out who's been in the clinic, right? It's one of the reasons that we run into some resistance, is some of our techniques are fairly aggressive, and they can cause bruising, and they can cause pain during the treatment. I think all of you here and the success of the clinic are a testimony to the fact that it's probably worth it, or it can be worth it. I do not want to say that it works every time, so sometimes it's not worth it. But overall, that pain and discomfort we're going through as we address the fascial system can give you very satisfying results and get you back to being active. I just want to throw up a picture of, this is our current osteopathic manipulative department of people taking appointments. We have a new one coming on. Anybody remember Dr. Rebar? Okay. His granddaughter is joining our practice in August. Okay, and she'll be an osteopathic manipulative specialist. You see Dr. Kate Carey up on the upper left, Dr. Mary Joy, Dr. Beth Chernick, myself, Dr. Milt Wright, Dr. Eric Schneider, and Dr. Day, Herb Day. So a lot of you have seen these people, and many of you have been treated by them. I'm happy that I can go teach, and there's still a whole group of people behind to try and fix the issues that may come up. A.T. Still said, when you deal with the fascia, you deal and do business with the branch offices of the brain. Okay? In my usual lectures, I have a lot of A.T. Still quotes, but this is one of my favorites. There's people in the osteopathic profession that say the fascial distortion model isn't osteopathic. Fortunately, we have a very large group of people on our side that say structure and function. So what do I mean? The fascial distortion model is simply a way that the fascia, the shiny stuff in your body, can get altered or disrupted, causes an alteration in function. So the abnormal structure causes abnormal function. I'll use an example. So say you have knee pain, and you've gone in and you've heard the story about your knee is bone on bone. Well, that's not ever a good thing, okay? It's also not how we function. So no bone in your body wants to touch any other bone, okay? So your body is under a system called tensegrity, and every bone tries to stay away from every other bone. And the joints and the way we're put together repels that. I don't know if we have any on campus, but if you see a suspension bridge or some of those tensegrity art pieces where you'll have solid structures separated by flexible structures, the solid structures never come in contact and they're kind of suspended in space. That's our body. So what happens when you have a knee that is not structurally working right? There's an alteration in the soft tissue and the function gets abnormal and it bonks into itself. That causes pain. You've heard that the meniscus, that pad that's between the bones, that's a pad. That absorbs the shock. That's not true, because if in a normally functioning knee, that's a spacer, it's not a pad, because that meniscus characteristic is not strong enough to support your own body weight. That's why if there's abnormal function, pressing bone on bone, that's why the meniscus is damaged, is because the structure of the cartilage and the nature of that meniscus isn't enough to support your own body weight. Same with your low back disc. If you bend over and lift up 75 kilos, if the idea of tensegrity wasn't real, the idea that every bone tries to go away from each other, you would explode a disc. It would just be done. The calculations are pretty interesting to see, but that's what happens. So when we're normally functioning knee, if they put a scope in it and you stand up, what do you think happens? I mean, based on the bone on bone thing, right? We come down and we push on that pad. But really what happens is the body repels the bones and the tension in the soft tissue tries to separate them and keep them apart. So a normally functioning knee is always trying to stay apart. So you can have a person where you do an x-ray and they have terrible looking knees. I mean, they have arthritis and they have no cartilage left and they don't have any pain. Well, why is that? Why do they not have pain and the next person with the same x-ray have horrible pain? It's because the person without pain has enough of their structure function system working that the knee is able to stay separated so they can be pain-free. So as an osteopath, my job is to try to get it so regardless of the damage you have in your knee, can we get it to be separated? Can we get it so that the function of your knee is doing what it's supposed to and pushing away from each other? And it doesn't matter if it's a knee or a shoulder or a hip or whatever. If you have bone on bone and you have terrible pain, you're going to need to see the orthopedist and get it fixed, okay? If we treat it and it gets better, you may not need to see the orthopedist for a while. Longest I've ever treated a hip that probably needed surgery was about 7 years. Gentleman wanted to retire before he got his hip done, and so we'd see him every 6 to 8 weeks. He knew he needed a new hip. I knew he needed a new hip, but he was able to get treated and be functional, and like very functional. And then eventually he got to the point where our treatment wasn't helping. He retired. He's like, okay, I'm going to go get my hip fixed. And so there is a ample place for the surgical correction of these problems, but it's not necessarily the reasons in our head. So I want to show you, so I've talked about what am I trying to do. I'm trying to get people to change their perspective. I'm sorry that this is a little dark. It's all right in some ways though, because the patient didn't want her face on there, so it's been pixelized, but you can't really see her anyway. What I want you to focus on is her arms, okay? Her arm movement. This is always when you start sweating and hope that it plays.
And then lift your arms up to the side. Okay, so your left hand won't go up anymore after that.
Okay? That's pretty obvious. No required medical training, right? Her left arm doesn't move. And again, I'm sorry it doesn't go up. You can't see it as well. It's great on this screen. You should all come up. No, kidding. So 7 years she's had this kind of movement in her left shoulder, right? 7 years, can't move it. She's been to the doctor multiple times. I'm not entirely sure what she's had done, okay? She's sitting in her bedroom, and I'm not anywhere in the vicinity, okay? This is after the treatment. He says after the second FDM treatment. That means he's treated what we call a trigger band, 2 of them. And let's see if we can get this one to play.
So we've just done the third FDM treatment. We did a trigger band with the anterior side of the arm going up onto the contralateral master process. And if you can lift your arms up to the side.
A little better color there.
You have to go smoothly.
You can correct the patient if it's your mother, apparently.
It's not hurting. It's not hurting. Okay, come back down.
So she's got much better range of motion.
Just very little bit. Just got a little residual pain. Residual pain, not like just that tightness in the feeling.
Here's one more or 2 more.
But your now we just did the 4th FDM treatment. Can you put your arm to the side?
Okay?
Wow.
So that's impressive, right? That's impressive outcome. Doesn't happen every time by any stretch of the imagination. The reason I teach what I do, that's a second-year medical student who took a module as a medical student who went home and treated his mom's 7 years of pain. That frustrates me. Why can't every physician in the country think in this model, watch the body language, think of the gesture and go, oh, I can do that. It's pretty simple, a lot of the treatments we do. We press, we push. I heard a great story, that's pretty much the analogy. Gentleman walks into this giant engine and it won't run. They try everything, can't get this great big engine running. So they call the expert. The expert comes in, he picks up a hammer and he goes, pink, and it starts running. And they said, okay, send us your bill. So he sends them a bill for $10,000. And they're like, what? And he said, yeah, $500 labor, the rest for knowing where to hit the engine, right? So in my job, I get paid really well. I'm glad of that. But it's knowing where to push, what to do with that. But it's not complicated. We can teach all the physicians how to do this. And that is When a second-year medical student can do this, I go to the family, I was just at the Mayo Clinic Mankato Family Practice Residency, and I love this because they all are like, ooh, yeah, cool. It's very obvious, and a lot of patients get good improvement in range of motion. Then I tell them a second-year med student can do something that either you as the attending physician or you as a resident physician or even as a fourth-year student can't. That should upset you as a doctor, that you're not able to do this. Now, I don't think every doctor should be doing osteopathic manipulation. I don't want my surgeons doing this. They are surgeons. I mean, if they want to, they can. But I want them to know about it. I want them to know that when you have a problem like this, there is a group of people out there. Just like if I do an EKG on somebody, you know, where we check your heart and make sure you're not having a heart attack, if I find the problem, I might be close to the last person you want to fix that. You want to go see Dr. Wren or one of his partners, okay? But if there's a soft tissue injury, there's a group of people, the osteopathic physicians and MD physicians who know the model that can help address this problem, okay? So we're working on the research. You may have heard of the interstitium. The interstitium was this big news article that was released in a scientific journal about the fluid in the fascia, and they called it a new organ. Well, they basically thumbed their nose at 12 years of research and said, yeah, great, whatever. We're going to call it a new organ and get the press. And if you can't say new organ, you got to say it with the tone of what he would do, right? So what does this mean very recently? This is a state track meet. So this gentleman came in to me, and he was having back pain. It had been about a week, and he had back pain. And he was really upset because he just qualified for state, but was pretty sure he wasn't going to be able to participate. And I got permission from his family to use these because they sent him to our clinic. His treatment was very short. I don't remember the exact length, but he had what we call a lumbar herniated trigger point, very common cause of back pain. So he stands up and he said, "What wizardry is this?" Which I thought was a great quote. And then he's without pain and he goes off to participate. What would our standard treatment for a sprain in the back have been for anybody? A couple of weeks of rest, anti-inflammatory, ice. There goes his track, finals, and he's kind of left with no opportunity to participate. So that is what we're trying to do at TVC in the osteopathic clinic. We're trying to churn that differential diagnosis upside down a little bit, have an opportunity to treat some things first, before we go down the long path. So what are some of the things that we treat? I have partners who enjoy treating babies, little babies like newborns, help with the latch mechanism. Dr. Carey is going to do a lecture on Thursday at the clinic or at the hospital regarding this information. They don't let me touch the babies. Actually, no, they do, but I have chosen not to because these guys love it so much. Headaches, back pain, neck pain, joint pain, acute injuries. You sprain your ankle, we can treat it. You may not have 100% relief. You may not have, you may need to go on down the differential diagnosis. Maybe you tore a ligament, who knows, but there's no risk at treating it. Sports injuries of all different kinds. Patients who've had strokes, we can actually make some improvements. I have several MS patients that get some relief from the treatments. Does it take away MS? No. But MS has symptoms associated with it. After you've had your surgery that saves your life, I have a lot of mastectomy patients. Doctors have taken care of the breast cancer and the radiation has helped and everything. We can sometimes address some of the tightness and the pain associated with that. We're starting hospital work where you may have the opportunity to be treated while you're in the hospital. It's early, so things that we're going to start with are hip and knee replacements. Dr. Joy, Dr. Carey, and soon to be Dr. Rebar have a lot of experience in their training where they go in, so you have your knee replaced, and they go in and treat you. Not necessarily with the aggressive, painful techniques that you guys love, right? That cause all the bruising. The surgeons twitch if we even talk about doing that. No, they do gentle techniques that have been shown to actually decrease your time from laying down to standing up so you can be more mobile. Pneumonia It's been shown to decrease your length of stay by a day and decrease your IV antibiotic requirement by a day. So these are things that we're working, because Fairbanks is progressive in accepting what they see as probably more anecdotal evidence. It works. That pneumonia has great research, but a lot of the other stuff we're working at getting the research behind it. So my students will tell me I'll treat anything, okay? And it's pretty true. I'll give it a shot. I don't know sometimes if it's going to work or not, but I'm willing to try, and so are most of my partners, because our goal is to get you more movement, to be more active, so you're more functional, so that you can heal yourself. And that is the osteopathic tenet. The more active you are, the more likely you are to be able to heal yourself. Activity is the best medicine. Food is probably the second closest. So, we have a few minutes for questions. Yes?
Perhaps you already said I missed it, or I didn't understand. I didn't have anything to miss it. You were saying the joints, they have a natural tendency to pull apart.
Yes.
What is that thing make it pull apart?
It's called tensegrity. Yes, it's the fascia, muscle, ligament, tendons. All of that
All that together.
is trying to just keep it separated. And it's the bones in your head, it's the bones in, it's every bone. No bone wants to bump into each other. Doesn't feel good.
So your ligament, your fascia, your muscle.
Yeah.
They want to keep it
Yep, they keep it apart. It's called tensegrity. Biotensegrity if you think about the body, yeah.
Does fascial manipulation help scoliosis?
So scoliosis is the curve in the spine. It depends on the reason for scoliosis. If you have degenerative scoliosis, that means your spine has kind of worn out on one side. It may or may not help. Some of the younger people, we can actually help with the straightening of it, but it's a multifactorial. It's going to be physical therapy, in my clinic, Pilates. We're going to get strengthening. We're going to treat the issues. It really depends on why you have the scoliosis, but we see a fair number of young people. Dancers, gymnasts are very common to have scoliosis because they favor a leg, and then that causes a chain of problems. I don't remember the percentage, but it's a large percentage of ballet dancers that actually have scoliosis. And you look at them and they're as strong as anybody. But we work with those gals and we try to create a symmetrical improvement and get them more functional. Yeah, so Ken.
Now, what about tibial bone bruises? Is osteopathy contraindicated for perineal?
How did they get the bruise?
From falling out of the kayak?
No. So a bruise of the bone, like periosteal, like the bone bruise itself, depends on what you show us. So what we key off of, actually, this is also a difference of what the osteopathic clinic does. Most of the time you go to the doctor, you want them to tell you what's wrong, right? I have stomach pain. Why? When you come into the osteopathic clinic, we ask you, what's wrong? Show us. And so that bruise, if you demonstrate a particular body language, that keys me in on what I need to do. And so you're actually the expert, and you tell me what I need to do. I put it in a fairly simple framework, and then I'm able to tell you if I think it can help or not. And how you demonstrate. Often we can't get rid of the bruise magically, but we could help some of the pain associated with the bruise, or a stress fracture, or an actual fracture. Can we heal fractures with the treatment? No. Can we reduce the pain associated with the fracture? Absolutely.
Absolutely. Question. Are squats bad for you? We were at coffee this morning, and one guy says, he used to do 180 squats. The doctor says, don't do that. That'll ruin your knees. And I don't believe.
Wow, that's a tough question. Are squats bad for you? I would say squats done improperly are bad for you. But if it hurts? Yeah, in general, no. Squats are not bad for you. Yeah, I would agree with that. Now, if you go as deep as you can and you have pain, it's probably not a good thing for you. Better to find out why.
How many weeks or months are you booked up?
It depends on which one of us you see, and it's usually within a couple of weeks right now. I think it's within a couple of weeks. And there's a lot of us, thank God, and that's why, because you don't want to have to rely on one person, because I go about once a month to teach, and you want me to have backups, yes.
So how does it help remote it?
So osteopathic medicine, you can help move the diaphragm and improve the lymphatic circulation. The lymphatic circulation is what kind of gets the anti-inflammatory fighters to mobilize, and you improve lymphatic flow and blood flow and circulation. You know, I'm not an expert on that particular thing, but I know that glucosamine has some good evidence that it ends up in the joints, and I think it's worth a try. So if you're looking for a glucosamine supplement and you try it and it seems to benefit, then it's good. But I wouldn't take it indefinitely if it doesn't seem to have made any change. They've done cool research where they radio label it on a rabbit, and they give it to the rabbit, and it ends up in their cartilage.
There's a question here, yes.
I was wondering if you image these fascial distortions?
So if you're a scientist, you're hired. Okay, so the question is, can you image these distortions? So we think we can, and we're working with some of the radiologists to try and find them. Frankly, it's at least a full-time dozen people trying to come up with this. I have an ultrasound in my clinic, but if I ultrasound something, there isn't a person in this room should believe what I find. You need the right kind of radiologist who has the training to be able to say, yes, this is it. So right now we have one of the radiologists in town who's musculoskeletal boarded. So we bribe him with lunch to help us and say, hey, can you help us see if this is a reality? I've worked down in Yakima looking at cadavers to see if we can identify these things. Simple answer is yes, I think we can. It's now getting the manpower to try to find these things.
And so in the meantime, are you just
Palpation.
and see if it works?
So it's palpation, and the patient guides us. If any of the patients in here, you know we look for the most tender spot, right? It's like, where is it? And when we're not on it, you tell us, you're not on it. And then we move our thumb or finger a little bit, and you're like, yeah, that's it. And your whole body lights up, you get that cold sweat. You learn that you can really swear. I mean, the profanity that we hear, you guys, you should be ashamed. No, I'm kidding. Go ahead.
I have a real basic question, and that is, I'm not ever and never have been clear as to why you are a DO and somebody else is an MD, what that distinction means, and why is there a distinction?
So what's the difference between MD and DO, and why is there a distinction? So MDs, DOs, we learn the same medical school, biology, biochemistry, all that. The DOs do 2 additional years at the same tract of manual skills, so these skills. So every DO learns these, not every DO carries on and uses it. Some of them frankly don't believe it, some of them don't think it's effective, and I personally, my big quest is to get FDM in there, into the osteopathic curriculum, because it makes you believe that this stuff works. If you don't think something works or you don't get good at it, you're never going to use it, okay? So the distinction long ago, when AT still came up with this, is the MDs were focused on medicine. And you had to take this and this and this, and this was going to cure you. He was developing his thoughts during the flu epidemic, and he lost several family members to the flu. He got really good results by mobilizing tissues, just like the pneumonia question. Mobilizing fluids, he helped his patients and get over the flu faster. And so this idea that the mobilization of the body, the structural alignment, we've all heard, is going to help fluid motion so the body can heal itself. The MD philosophy at the time was medicine's going to fix you. Now, as we get towards 2018, it's really hard to say that MDs don't think holistically. That is the word that has been tagged to the osteopathic profession, but I don't subscribe to the DOs are holistic and MDs are not, because we're a continuous, we all look at the body holistically. Nowadays, there's a separation because frankly, osteopathic medical schools make money, MD medical schools make money, and you're never going to get anybody to stop taking students. Really, there's a lot of money in medical education. In the next 4 years, 25% of the physicians that graduate from medical schools will be DOs. And so the DO population is growing. You're going to hear more of it. They're surgeons, they're everything. But yeah, the differences before and now, it's like asking why are there PAs and nurse practitioners? They can both do very similar. Nurse practitioners practice on their own. PAs have to have a collaborative physician. They do a lot of the same things. Why are there difference? Different degree program now.
You mentioned working with pneumonia. Does it help anything at all with this catch-all phrase of COPD?
There was a recent study that showed that there can be some improvement in overall lung function. COPD is, a multifactorial issue, but it could possibly. It's not something I focus on a lot, but yeah, I think there's chances, especially if it's associated with pain. If there's pain.
So I hope you don't take this question the wrong way, but and I'll press it by saying I went to the dental clinic years ago and had back pain. When I saw the deal there, and it was wonderful, and I had to go back for a revisit, and I saw it. And it was still a clinic. He didn't know anything about my back. He was not an MD, and so I thought
He was an MD?
correct.
Yeah.
And I really was absolutely impressed about the manipulation. So, and 10 years later, I had that spinal
Surgery.
yeah, but it was really safe. I liked it then, but so I really do believe in DO.
Right.
The presentation you made is largely based on, it's not so much based on data and data versus the medicine. Maybe it goes to what Rich was saying about the difference between the approach of ND, and a lot of what you're saying would be more in the realm of anecdotal evidence that it works.
Right.
Now the gluten-free diet issue and the explosion of people who think they had celiac disease, which now it seems to be clear that didn't happen.
Right.
Because the placebo effect, you haven't mentioned placebos at all, but they're, of course, they're giant.
Yeah.
Who doesn't like the human touch? So that's the only thing that...
So do you think that first DO treatment was human touch and it was a placebo treatment?
No.
There you go.
It could have been, however, but the most powerful organ in our body is
Our mind.
are made.
Yeah.
So
Yeah, so you asked.
So I'm just asking about data, because what you...
So physical data, it is accumulating. I showed you those 3 textbooks. If you want to fall asleep quickly, read those. There's 4 now. There is data. There's not enough. No doubt that there is not enough to support what I'm saying. But if we are able to get... So actually, I was just reading tonight, there's an NIH article in the American Academy of Osteopathy Journal that basically says the NIH has discriminated against the osteopathic profession in research grants. There's never been an osteopath in charge of the NIH. There's never been an osteopath, all of this stuff. I haven't fully digested the article, but I can tell you from my personal experience, we've had case studies. Case studies are where you start research. We've presented case studies to a journal, and the person has a conflict of interest because they know a different fascial manipulation, it's called, style. And he wrote back saying, I don't care what my reviewers say, I'm not publishing that, even if they like the article. And so you got this conflict of interest, but you can't get past it. We had a great dermatology case that we presented, and we wrote it up. We had a wonderful dermatology piece written by our dermatologist. We present it, and they're like, it's unbelievable, we're not going to write it. We had another one so the students who are learning this, I just got a text as I was walking in here, had a great treatment of a young pitcher who the family thought he was going to be out. He's a 3rd-year medical student, treated him, got him better, spent the time talking about the fascial distortion model. Each of those case studies is anecdotal, but when we write them up, we run into things like this shoulder I showed you. Somebody will say, well, it's too good to be true. Well, how do you overcome that? I mean, I'm with you. I want the evidence.
Well, basically, it's like that TEDx example is the classic case of people not seeing the error. I use that example many times.
Yeah.
virtually nobody sees it at first. However, could you just tell me what's the difference between DO and chiropractic? 'Cause
So it's part philosophy, and much of the chiropractic, and this is my opinion, so if I'm wrong, and if there's any chiropractors in the room, you can correct me, very spine mediated. So the chiropractic profession is very spinal focused. So everything is associated with spinal level, and alignment of the spine will fix things. So it'll cure things. Many of the chiropractors have branched away from that, incorporate other modalities, but that's the core. In the osteopathic profession, soft tissue, bone, they're all seen as equally important, and we're looking for normalizing function, whether it's the soft tissue. The example I use is if your spinal manipulation, and I do spinal manipulation, very similar to a lot of the chiropractic moves. The first chiropractor was a frustrated osteopath, okay? And so if I'm a vertebrae and I'm out of place, and I come along and shove you back into place, you may get pushed right back out of place because there's soft tissue tension in the system, okay? As an osteopath, I can either shove you back in place or I can address what was pulling you out of place. And that's the difference in a nutshell.
See, I think this is a failure of the medical system because the fact that these modalities, like you said, are not integrated reveals some fundamental
There has been, over the years, there's been a lot of animosity between all three groups you just mentioned.
Yeah. Good question.
Actually, I have a comment. This is really not new. About 25 years ago, my husband and I and a whole group were at Delta Junction.
Dr. Andreasen.
Container and couldn't walk. I mean, he literally couldn't stand up. He was in horrible pain. Delta Junction, or Delta had a DO.
Dr. Andreasen, I think he's still there.
Yes.
Yeah.
We went to him. Obviously, that's the first place we're going to be. He said, okay, he said, I can do one of two things. He said, I can, put you on bed rest, put you on ice, put you on aspirin. You'll spend 3 weeks not be able to move. He said, or I'll fix it right here.
And that's Dr. Andreasen. Yeah, he used that analogy.
Yes.
And he used that. He is responsible for bringing fascial distortion model to Alaska. The gentleman who created it was Dr. Topaldis. Dr. Andreasen was good friends with Dr. Topaldis, and he brought him here to teach it for 3 different trainings, and then he passed away, age 49. So my job is to carry on what Dr. Topaldis had done. And so yeah, Dr. Andreasen has been doing it for a long time. I'm not the only one who does this.
My husband got up and walked out.
Yeah.
He was never in any more.
But how do we study that? It's an N of 1, right? You can't study that. We can figure it out. I've spent the last year trying to get or 2 years now, trying to get a research project going at our clinic with helping because I potentially have a conflict of interest because I wrote a book, okay? And they tell me at some day I could potentially make money from said book. It's never gonna happen, but that's the threat. Anybody write a book in here, you know what I'm talking about. So that research project took 1 year for a student to get through the IRB process, took another year where we got like 2 people to volunteer for the study, and so you still don't have anything. And this is 3 or 4 people working on it full time. So trying to get that research done, I'm honestly going to spend the next few years trying to make that happen because I'm seeing the lack of it and nobody else is stepping up. It's not my passion. I love treating people, I love teaching, but we need more research. There was a question right here.
Well, my question is a comment. You wrote a book and you didn't mention it. What was on the just there?
Well, yeah, it's available.
You haven't talked too much about lower back pain or anything. Can you talk about that, or maybe a lot of it
sucks. Yeah. Whoops. Edit that. Low back pain, very, very common diagnosis. It's again one of those things that we launch into immediately. It's the disc, right? It's immediately a disc or a problem, and that is what the medical world thinks it is, and you all think it's sciatica. Right? So my rule of thumb is if somebody tells me they have sciatica, it's 90% chance they don't. Because sciatica is an overused term. It's like rotator cuff. It's synonymous with shoulder pain, okay? So low back pain, lots of different causes. If we get it early, we might be able to change that function in the back and prevent it progressing, okay? So, depends. When does it hurt? How does it hurt? Show me where it hurts. And we treat a lot of back pain. I had one gentleman who was working on the haul road as it was being put in, and he had back pain for 50 years. He was on chronic pain medicines, all this stuff. And the third-year medical student with me treated his back pain and was gone in 30 seconds. Okay, so it can be, but then you get somebody else, you do the right stuff, and it doesn't help. It's not the answer. You have the whole differential diagnosis for a reason, you know. I refer to the neurosurgeons and the orthopedic surgeons for surgery when it doesn't help. What I don't like is when they go into that system and it's your disc, because we know the MRI. If I MRI'd everybody in this room, there's about 100 people maybe close, 30 of you would have a herniated disc. And it may have nothing to do with your pain, okay? And so we know the MRI is an extremely sensitive test. It's a dangerous test to order because once you know you've got a herniated disc, what happens? You better get it fixed or you better change your lifestyle, right? So I had a gentleman, we treated his back pain went away. He knew he had a herniated disc. He still went to the operating room to get it fixed. First of all, I don't think the person's still practicing, so shame on the doctor for correcting that because it wasn't causing pain. You should never go through a procedure if you're not having pain as the pain or some sort of dysfunction is the reason. You know, because that whole thing, if his spine is working correctly, he can get away from his own disc. He can repel himself, the bones apart, and he doesn't need surgery. They heal on their own. And fortunately, we got great surgeons in town who I don't think overdo it. So I'm happy to work in this climate. Yes. 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 EMG positive carpal tunnel, I would be leaning towards surgery. EMG negative, which is the electrical stuff, we actually treat quite often. Yeah.
2 more questions.
Okay. Yes. So osteoarthritis is basically calcium depositions or redistribution of bone. So it's like going where it shouldn't. Okay?
You had headaches on your list of things you treat. Do you treat migraines and debilitating dizziness?
Yes. I don't know if it, well, some people. I can't say it works all the time though. I'd be lying if I did. But yes, I treat migraines. We all treat, I shouldn't say I. We treat migraines, we treat dizziness. Sometimes it's effective, sometimes it's not. Very often it is. Yeah.
Do you work with people who are exploring prolotherapy with joint issues?
Yeah, so we have actually, Dr. Chernick used to do a lot of prolotherapy. And after learning the fascial distortion model, she essentially stopped. And there's people in town who are using prolotherapy or PRP, the plate-rich plasma, or the stem cells. And you can do that, and it works together. We just don't do it as part of our clinic.
But are they at odds with one another because of the inflammation?
No, actually, prolotherapy is trying to increase your inflammation. We don't tend to use anti-inflammatories, so we're not trying to increase inflammation either. So we're not telling you to take ibuprofen. Ice would be the biggest anti-inflammatory we have. It's probably your best anti-inflammatory. So you don't need to take a pill, just ice something if it's sore. But yeah, prolotherapy, it works just streamlined with. Yeah. Yeah. Yep.
Okay, so I'm the bad guy. Or whatever. Anyway, thank you so
Yes.
very much.